So that's all about antivirals. Let us go into antifungals. Now antibacterials are over, antivirals are over. After antifungal, you will know to deal with most of the microorganisms. So what are antifungal drugs? They are drugs which treat superficial or deep mycosis. Superficial or deep fungal infections are treated by these drugs. The classification is like this. It is classified into topical and systemic drugs. The topical drugs are again classified into polyenes, imidazoles and miscellaneous drugs. Polyenes, imidazoles and miscellaneous drugs. Systemic drugs again subclassified into 5. 1 is antibiotics, 2 antimetabolites, 3 azoles, 4 allyl amines and 5 is echinocardins. You will be familiar with most of these names. Just take care to remember that which drug falls under which group. So the first topical group was polyenes. Polyenes are nystatin, hamycin, natamycin. Get aminoglycosides which are streptomycin, gentamicin, tobramycin. These are nystatin, hamycin, natamycin. And what is the mechanism of action of polyenes? Look in the figure. A fungus has an outermost cell wall. Inside to that we have a cell membrane. Then we have the nuclear membrane and nucleus. So polyenes acts upon the cell membrane. Polyenes forms pores in the cell membrane. This leaks the content and kills the fungus. Next one is imidazole group. Imidazole groups are all azoles. Clotrimazole, miconazole, iconazole. Azoles have the similar mechanism of action, acts on the cell membrane, but it acts on the ergosterol synthesis inside the cell membrane. Then we have some miscellaneous drugs for topical application like anticyclic acids and benzoic acid. Coming to systemic ones, the first group is antibiotics which acts as antifungal. So the first one is amphotericin B, the second one is griseofulvin. You are familiar with the names, I'm sure. Amphotericin B, what it does, it binds with the ergosterol in the fungal cell membrane and forms pores in the cell membrane and leaks the contents out, just like the polyenes. Antimetabolites like flucytosine acts on the protein synthesis of the fungus. You can see from the figure, flucytosine acts on the protein synthesis. Then we have azole group. Azole groups also affect the cell membrane of the fungi. It affects the ergosterol synthesis. Allyl amines like terbinafine also affect the ergosterol synthesis. So most of the drugs targets the cell membrane of the fungus. When I tell you about terbinafine, I want you not to get confused with the drug terfenadine. Terfenadine is an antihistamine. Okay. So it is an anti-allergic drug, but it has been withdrawn due to its cardiac arrhythmic potential. So that is terfenadine, and our antifungal is terbinafine, which acts on the cell membrane of the fungus. Finally, we have something called echinocardin or pneumocandins. They act on the cell wall of the fungus, that is the outermost layer, the cell wall. Cell wall synthesis is affected. Example is capsofungin. So capsofungin is an echinocardin or pneumocandin which inhibits the cell wall synthesis of the fungus. So if you see your textbook, I have referred Padmaja and Udayakumar here. You can see in the chemotherapy section there are antibiotics, antivirals, antifungals, then anti-tubercular therapy, anti-malarial therapy, anti-helminthics and anti-protozoal therapy, cancer chemotherapy. It is a big section indeed. So whatever is very important for us, whatever has been repeatedly asked for exams, we will cover now. So anti-tubercular and cancer chemotherapy is an important portion. Many questions have been asked from this. So next we'll be going into anti-tubercular drug. Then we'll deal with cancer chemotherapy. All the remaining small things we'll cover in the miscellaneous chapter. So going into the anti-tubercular therapy. Tuberculosis is a bacterial infection caused by Mycobacterium tuberculosis. So why are we considering it separate, anti-tubercular chemotherapy? Because it is a difficult disease to treat. So there are first line drugs for the treatment of TB and there are some second line drugs. The first line drugs are always high efficacy drugs with low toxicity. So this is the group of drug that you should prefer first. These drugs are streptomycin. Streptomycin is an aminoglycoside. Then isoniazid, ethambutol, rifampicin and pyrazinamide. The shorthands given for these drugs are streptomycin S, isoniazid H, ethambutol the same E, rifampicin the same R, and for pyrazinamide it is Z or Z. So these are the first line drugs. When the first line drugs fails, you can go for the second line drugs. Second line drugs are low efficacy drugs with a higher toxicity. So these are only reserved drugs. They are not recommended. So in extreme cases, maybe you can use this along with the first line drugs. Such drugs are ethionamide, fluoroquinolones, amikacins and kanamycin. First is isoniazid. Isoniazid is a first line drug and it is tuberculocidal for rapidly multiplying bacilli, but it's static for resting bacilli. So it's tuberculocidal only for rapidly multiplying bacteria. For static bacteria, for resting bacteria, it is only bacteriostatic. What is its mechanism of action? It inhibits the mycolic acid, that is a cell wall component of the bacteria. So it destroys the cell wall of the bacteria. Acts on extracellular as well as intracellular bacteria. That is an advantage. It can act in acidic and alkaline medium. And one more important thing is it is the most effective and cheapest drug. So it is most effective for its price. The adverse drug reaction that is most commonly encountered is peripheral neuropathy and hepatitis. So it can affect your head, it can affect your stomach also. Okay. Why I said head? Because it is showing many neural symptoms like psychosis and even seizures are seen, but that are less common side effects. Peripheral neuritis is the commonly encountered side effect. So peripheral neuritis, you should remember isoniazid. Next first line drug is rifampicin. Rifampicin is a strong drug. It is very effective, especially effective against persisters. Persisters means even after having anti-tubercular therapy and eliminating the bacteria from the bloodstream, some bacteria persist in our tissues. So rifampicin is effective even against these persisters. Also, it is effective against bacteria which are resistant to other anti-tubercular drugs. Acts on intracellular as well as extracellular bacteria and acts on all the subpopulation. Slowly and intermittently dividing bacteria are also acted upon. So, such a very good drug. What is the mechanism of action? It interrupts the RNA synthesis of the bacteria. So, you can connect that with the R. Rifampicin interrupts RNA synthesis. Then this drug is a hepatic microsomal enzyme inducer. That is an important question. Since it is an enzyme inducer, it can have drug interaction with many drugs. It induces the metabolism of warfarin, phenytoin, oral contraceptives, steroids, NNRTI antivirals, protease inhibitors, all these drugs. Even though rifampicin has many CNS as well as hepatic side effects, the interesting side effect is rifampicin stains the secretions orange red. The tears, the saliva, the sweat, everything will be orange red in color. So we should inform the patient about this, lest the patient is going to get scared. So rifampicin, red urine, saliva and tears. Okay. Next is pyrazinamide. Pyrazinamide is also a bactericidal. It is a weak bactericidal. It is more active in medium. This drug is very active in the first 2 months of administration. It kills all the residual bacteria. Its mechanism of action is it gets converted into a metabolite called pyrazinoic acid, which inhibits the mycolic acid, just like the isoniazid. Most common adverse reaction is hepatotoxicity. It also causes hyperuricemia and gout. Hyperuricemia and gout you should remember. Ethambutol is the next drug. It is tuberculostatic. All the other first line drugs are tuberculocidal, but ethambutol is static. With the HRZ regimen or the isoniazid, rifampicin, pyrazinamide regimen, this is used to prevent resistance. So HRZE is a regimen. Its mechanism of action is it inhibits arabinosyl transferase and thus preventing mycolic acid incorporation to the cell wall. It is not destroying the cell wall after it is formed. It is preventing the formation of the cell wall by preventing mycolic acid incorporation. Adverse drug reaction of ethambutol is a very important question. It causes optic neuritis. It affects the eye. So ethambutol E affects eye. That both E's you should connect. It causes optic neuritis. There is loss of visual acuity and it affects the color vision, especially the red and the green colors. Okay. Streptomycin is a drug of aminoglycoside group. This was the first clinically useful anti-TB drug, but it is least preferred now because of its side effects, and when we weigh the risk-benefit ratio, it is not considered very useful. It is cidal, but it is less effective than INH or isoniazid.
and rifampicin. What is the mechanism of action? Misreading of mRNA. Streptomycin causes misreading of mRNA. When we learned antibiotics, we learned aminoglycosides and tetracycline inhibit protein synthesis, and it binds to 30S ribosomal subunit to do this. So its mechanism of action is misreading of mRNA, hence preventing protein synthesis. Already discussed, its adverse drug reactions are ototoxicity, nephrotoxicity, and neuromuscular blockade. Now, how should we treat TB? TB should be treated in phases. First 2 months is the intensive phase. 4 to 6 drugs can be used, and in this phase it rapidly kills the bacilli and brings the sputum conversion. Then for 4 months it should be continuation phase. Okay. Here you can use 3 to 4 drugs, and this is to eliminate the remaining bacilli and prevent relapse. One special consideration is streptomycin is contraindicated in pregnancy and breastfeeding. Already we mentioned streptomycin is the least preferred drug, and strictly it should be not given in pregnancy and breastfeeding.
Next is cancer chemotherapy or anti-cancer drugs. Anti-cancer drugs, what they do, they either kill or they modify the growth of the cancer cells. Cancer chemotherapy is employed for either it is employed for curing the cancer or for a prolonged remission of the cancer. The second reason of using this drug is palliation or pain relief. And the third is it is given as an adjuvant to other cancer treatments, maybe to radiation therapy, and adjuvant chemotherapy can be given. So Paul Ehrlich is the person who coined the word chemotherapy. What are the most common side effects of anti-cancer drugs? It is bone marrow suppression, alopecia, and mucositis. So bone marrow suppression is the major side effect. Alopecia, as we all have heard, chemotherapy causes loss of hair, and mucositis is also very common. So these cytotoxic drugs can be of two types: cell cycle non-specific and cell cycle specific. The drugs which are not specific to cell cycle, they can kill resting as well as dividing cells, and cell cycle specific will kill only actively dividing cells, meaning to say mainly these drugs will affect the cells in the S phase. The toxicity is expressed in the S phase. Coming to the classification of anti-cancer drugs, the first group is alkylating agents, those drugs which are capable of alkylation. This is again subclassified into 5 groups. This can be remembered by using NEAT, N-E-A-T. So there are 2 classes starting with N, nitrogen mustards and nitrosoureas. Then we have ethyleneamines with E, alkyl sulfonates with A, and triazenes with T. So alkylating agents are NEAT. The first one is nitrogen mustards. To remember the nitrogen mustards, you should remember me on cycle to Infosys met with corona. I was going to Infosys on my cycle and I met with corona. Me on cycle to Infosys met with corona. Me is mechlorethamine. Okay, cycle cyclophosphamide. Infosys is ifosfamide. Then met is that M is melphalan, and corona, that C stands for chlorambucil. So that is nitrogen mustards. Nitrogen mustards, you should remember me on cycle to Infosys met with corona. After that, the second N, nitrosoureas, because you went on cycle, you met with corona, you want a car. Now car is a must. So carmustine you should remember. Along with carmustine, you can easily remember lomustine, and you have one more drug called streptozocin. Okay, so that is nitrosoureas, carmustine, lomustine, and streptozocin. Then ethyleneamine ends with the term amine. Alternate amine you have, and one more drug you have, thiotepa. So ethyleneamines are altritamine and thiotepa. Then you have alkyl sulfonate group, the A. Alkyl sulfonate group has a drug called busulfan. That is also an important drug, okay, busulfan. So I remember this like already cycle came and car came into the picture. Now bus has also come, busulfan, okay. And finally you have triazenes. Triazenes you can remember, now you have one more trick to remember this, that is it is a sulfonate. So busulfan term has that sulfa in that. So you can easily remember. So now since you have a car, you can party your dinner time. So that is your final group, party dinner time. That is procarbazine, decarbazine, and temozolomide. procarbazine, decarbazine, and temozolomide. Only temozolomide is out of the box. Remaining, it is clear from the term azine. Triazine group has two drugs ending with the term azenes, procarbazine and decarbazine. So alkylating agents are neat. In that neat, you have nitrogen mustard, nitrosoureas, alkyl sulfonates, ethyl amines, and triazines. And for nitrogen mustard, you should remember Meon cycle twin forces met with corona. For nitrosoureas, therefore you want car must. So the car mustin, low mustin, and streptozocin you should remember. Then ethylamines end with the term amine, altritamine, and thiotepa also you should remember. Alkyl sulfonate, the term sulf should come, so du-sulfan. And triazine is finally parting the dinner time, PDT, procarbazine, decarbazine, and temozolomide. After alkylating agents, coming to platinum compounds, it is easy to remember. All the drugs have platin in their names. Cisplatin, carboplatin, oxaliplatin. Easy, right? Then we have anti-metabolites. When coming to anti-metabolites, we have pyrimidine analogues, purine analogues, and folic acid analogues. So these drugs are the analogues of purines, pyrimidids, and folic acid, and they inhibit the purines, pyrimidins, and folic acid, thus inhibiting the metabolism. So this full class anti-metabolites are concerned with cinema. Pyrimidine analogues you should remember by the term 5-cinema gems. So 5 stands for 5-fluorouracil. Cinema C is for cytarabine and gem is for gemcitabine. So pyrimidine analogues are 5-cinema gems. Purine analogues, you should remember the 5-cinema gems. It is a weird combo, but anyway, Mammootty, Tovino, Charlie Chaplin, and Prithviraj. Mammootty's M is for mercaptopurine. Tovino's T is for thioguanine, and they have the prefix 6 mercaptopurine and 6 thioguanine. Charlie Chaplin C stands for cladribine. Then Prithviraj's P stands for pentostatin. So these are the purine analogues. In the purine analogues, we name some cinema gems: Mammootty, Tovino, Charlie Chaplin, and Prithviraj. That is mercaptopurine, thioguanine, cladribine, and pentostatin. Then folic acid analogues are Matinee Pictures, MP. The 5 cinema gems movies are coming in Matinee Pictures. So methotrexate and P for pemetrexate. So methotrexate and pemetrexate. Next is Vinca alkaloids. It is easy to remember. The drugs have the term Vin in them. Vincristin and Vinblastin. Again, taxanes have Taxol in them. Paclitaxel and docetaxel. Then we have epipodophylotoxin, and this class has the drug known as etoposide. Then we have camptothecin. Camptothecins are topotecan and irinotecan. Thecins and tecans, right? Camptothecins are topotecan and irinotecan. Then we have one more class, anti-tumor antibiotics. You can remember that using this term, active and blue dacini. All of you know dacini, right? You will know. So the active and blue dacini is the A is actinomycin D. The second A is anthracycline. Anthracycline is a group which harbor many drugs like donorubicin, doxorubicin, epirubicin, idarubicin, and mitoxantrone. So mostly they are rubicin drugs, anthracyclines. Then blues, B is for bleomycin, and dacini, dactinomycin. So for anti-tumor antibiotics, you can remember active and blue dacini. Now there are some miscellaneous drugs which are not put in any of the previously mentioned groups. Hydroxyureas, L-asparaginase, and imatinibs are also cancer chemotherapeutic drugs. Then we have hormones and related agents. Corticosteroids like prednisolone and prednisone can be used. Anti-estrogens like SCRMs or selective estrogen receptor modulators. Then we have aromatase inhibitors. We have Tein and Zol drugs in that group, all ending with Tein or Zol. Then we have progestins like medroxyprogesterone acetate. Then we have estrogens which end with the name esterol or estradiol, and we have androgens like testosterone. These are not very important. Anyway, for the completion of the classification, I have put. Similarly, flutamide anti-androgen. Then we have GnRH or gonadotropin releasing hormone analogues and antagonists. Analogues are leuprolide, and you have many drugs ending in relin: goserelin, nafarelin, buserelin, hysterelin. And GnRH antagonists are relix drugs: cetorelix, ganirelix, abarelix. Very good if you can remember.
Coming to alkylating agents, what they do the alkylation of the DNA strand and result in its breakage. So given below are some alkylating agents, and cancer they treat primarily. So mechlorethamine and cyclophosphamide, remember our code me on cycle to Infosys met with corona, so that mechlorethamine and cyclophosphamide both are used to treat Hodgkin's lymphoma. Chlorambucil on cycle to Infosys met with corona, that corona C is chlorambucil. Chlorambucil treats CLL, so there is one C and two L in the name chlorambucil, so it is easy to connect. It treats chronic lymphoid leukemia or CLL. Melphalan treats multiple myeloma. You can connect the M and the M, melphalan, multiple myeloma. So all these are nitrogen mustards. Then the alkyl sulfonate busulfan is used to treat CML or chronic myeloid leukemia. Nitrosoureas are primarily considered as the drugs which can cross the blood-brain barrier. So therefore, they are used to treat tumors inside brain. And cyclophosphamide, we already said it can be used to treat Hodgkin's lymphoma. But if the question is, the cyclophosphamide is a drug of choice for which disease? It is the drug of choice for venous granulomatosis. So clear with that? Anti-metabolite drugs which act in the S phase of the cell cycle. These drugs are having anti-neoplastic effect, we know. In addition to this, they have immunosuppressive properties also. So methotrexate and pemetrexed are the drugs. Their mechanism is inhibition of dihydrofolate reductase. So dihydrofolate reductase does not get reduced to form tetrahydrofolate. Uses of antimetabolites, especially methotrexate, can be remembered using methotrexate inhibit cancer. So you have to expand the inhibit cancer. Inhibit, you should remember, it is an immunosuppressant, we already mentioned. In the term cancer, each letter of cancer represents a disease which can be treated using methotrexate. C, Crohn's disease. A is used for abortion. N, it is used in non-Hodgkin's lymphoma. C for choriocarcinoma. E for ectopic pregnancy, and R for rheumatoid arthritis. So methotrexate can be used in all these conditions: for Crohn's disease, for abortions, for non-Hodgkin's lymphoma, for choriocarcinoma, ectopic pregnancy, and rheumatoid arthritis. If someone asks you methotrexate is the drug of choice for which disease, you should tell choriocarcinoma. Okay. This is also an important question. What happens in methotrexate toxicity? So methotrexate prevents the formation of tetrahydrofolate, right? So when methotrexate accumulates in body, there is no tetrahydrofolate in our body. To reverse this toxicity, we have to give folinic acid or leucovorin or citravorin factor. All these are the same: folinic acid or leucovorin or citravorin factor. This inside our body gets converted to a form of THF, and this can be utilized by the cells. So methotrexate toxicity is treated using folinic acid. Important question. Coming to purine analogs. Purine analogs or analogs means they act like the purine and competitively inhibit the purines. So purine antimetabolites, they are used for the treatment of mainly leukemias. Both acute leukemias and CMLs are treated using purine analogs. Purine analogs, you remember the drugs? We remembered that using 4 actors' names. Yes, Mammootty, Tovino, Charlie Chaplin, and Prithviraj. Mercaptopurine, thioguanine, cladribine, and pentostatin. So mercaptopurine and thioguanine are used to treat acute leukemias, Mammootty and Tovino. Fludarabine and pentostatin are used to treat CLL. And cladribine is considered the drug of choice for hairy cell leukemia. This also have seen in question papers. Cladribine is the drug of choice of hairy cell leukemia. Coming to pyrimidine analogs. Pyrimidine analogs, you remember 5 cinema gems. So 5-fluorouracil, C cytarabine, and G gemcitabine. So 5-fluorouracil is used in the treatment of carcinoma of stomach, colon, rectum, some GI organs, then breast and ovary. Cytarabine is used to treat acute myelocytic leukemia. Cytarabine is very effective to treat AML. Even in relapse cases, we can use cytarabine. And gemcitabine is the drug of choice for pancreatic cancer. So cytarabine and gemcitabine are pyrimidines, whereas fludarabine, cladribine are all purines. No confusions, okay? platinum compounds, we know platinum compounds are cisplatin, carboplatin, etc. Cisplatin is used to treat ovarian and testicular tumors and also cancers of the head and neck. What is the most common adverse effect? It is nausea and vomiting, and it is the maximum among all the anti-cancer drugs. So when we attribute vomiting to anti-cancer drug, the platinum compound is the main culprit. Out of this cisplatin and carboplatin, cisplatin is more nephrotoxic or toxic to the kidneys, and carboplatin is more hematotoxic. But if the question is dose limiting toxicity of platinum compounds, you should not write nephrotoxicity or hematotoxicity. It is neurotoxicity, especially it causes peripheral neuropathy. One more question is amifostin. Amifostin is a compound indicated for reduction of the cisplatin-induced nephrotoxicity. We said cisplatin is very nephrotoxic, so to reduce this we can use amifostin. Amifostin is also used to reduce xerostomia in patients undergoing irradiation. You would have learned this in oral pathology. When the saliva is less and the patient's oral mucosa dries out, we use amifostin. Same amifostin is used for reducing nephrotoxicity of cisplatin. Doxorubicin and daunorubicin are anthracyclines, which are anti-metabolite drugs. They inhibit DNA synthesis. So out of this, daunorubicin is used to treat acute leukemia or blood cancer, whereas doxorubicin is useful for solid tumors. Unlike daunorubicin, which treated the cancer of the blood, doxorubicin treats tumor of solid organs. Coming to camptothecins. What drugs are camptothecins? Topotecan, irinotecan, tecan, and thecins. You should connect. Camptothecins inhibit DNA synthesis by inhibiting which enzyme? Topoisomerase 1. So irinotecan's major side effect is it inhibits the enzyme acetylcholine esterase. So when acetylcholine esterase is not there, acetylcholine accumulates and it increases the cholinergic effects. Coming to our epipodophylotoxins, which are etoposide, teniposide, such drugs. They inhibit topoisomerase enzyme 2. Topoisomerase enzyme 1 was inhibited by camptothecins. Topoisomerase 2 is inhibited by epipodophylotoxins. Usually they are used to treat testicular and lung cancers. Then we have taxanes. Taxanes are paclitaxel, docetaxel, such drugs. They affect microtubules and arrest mitosis. That is a mechanism of action. They affect the microtubules. Finally, about vinca alkaloids. Vinca alkaloids, examples are vincristin, vinblastin. They are spindle poisons. So that is the mechanism. Vinca alkaloids are spindle poison. Out of this, vinblastin is found to exert bone marrow suppression. So BB you should remember, blastin causes bone marrow suppression. Vincristin has less of this bone marrow suppression and it is more of a neurotoxin. Clear? Coming to some important side effects. First, distinctive toxicities of alkylating agents. Cyclophosphamide causes alopecia or loss of hair, which is a common side effect of anti-cancer drug. Hemorrhagic cystitis, you should remember. We'll expand about hemorrhagic cystitis. Then it also causes SIAD. SIAD is syndrome of inappropriate secretion of ADH hormone. Ifosfamide also causes hemorrhagic cystitis and SIAD. Cyclophosphamide and ifosfamide, you have to remember hemorrhagic cystitis. Busulfan causes pulmonary fibrosis. This question has been asked repeatedly. That's why I put a star mark there. Busulfan causes pulmonary fibrosis. Also causes hyperpigmentation, adrenal insufficiency. The major side effect is the one that you should remember. There will be multiple side effects for every drug. Okay. Procarbazine, it is used to treat leukemia and it causes secondary leukemias. Also causes disulfiram-like reaction, behavioral changes. Cisplatin, we already mentioned, platinum drugs are most common ones to cause emesis or vomiting. It also causes nephrotoxicity, very toxic to the kidney. Then peripheral sensory neuropathy and ototoxicity can also be caused. So about hemorrhagic cystitis, the degradation product of cyclophosphamide, acrolein, is responsible for the hemorrhagic cystitis. This is also an important question. What causes hemorrhagic cystitis? The product of cyclophosphamide or ifosfamide, acrolein, is causing this. What is used to treat this hemorrhagic cystitis? It is MESNA, that is sodium 2-mercaptoethane sulfonic acid, which is denoted using the acronym MESNA. It is used to treat this hemorrhagic cystitis. Hemorrhagic cystitis is an inflammation of the bladder and there will be hematuria. Then we have side effect of nitrosourea, which is delayed neutropenia. So nitrosourea causes neutropenia. Connect the N and the N. Now there is something called hand and foot syndrome. Hand and foot syndrome is caused by 5-fluorouracil, capecitabine, which is a prodrug of 5-fluorouracil, doxorubicin. This is considered as a form of erythromelalgia. Erythromelalgia means it is a vascular disease causing peripheral pain of hands and foot, and it is manifested as tingling, numbness, pain, erythema, swelling, and increased pigmentation of the hand and the foot. So our presentation is done, but there are a lot of things outside of this which can be asked also. So please be sure that you refer your textbooks. Don't depend upon the presentation or depend upon the dental pulse alone, because dental pulse is also having only limited number of questions from chemotherapy. So be very sure that you go through your textbook, your Padmaja and Uday Kumar or Tripathi, whichever you are referring. Okay. In case of any doubt, you can contact me. Thank you.